All right, hello everybody. So my name is John Chacon. For those who don't know me, I'm a PGY1 pharmacy resident here at Stony Brook University Hospital. Today I'll be presenting Tackling the Trojan Horse, Prevention and Treatment of Acute Graft-Versus-Host Disease. So I have nothing to disclose. And the pharmacist objectives for today are describe the pathophysiology, signs and symptoms of acute graft-versus-host disease, apply risk scoring tools for assessing grade and stage of acute graft-versus-host disease in allogeneic hematopoietic stem cell transplantation recipients, demonstrate understanding of prophylactic treatment for acute graft-versus-host disease prevention, appraise the efficacy and safety of current treatment options for acute graft-versus-host disease, and examine the role of hematopoietic stem cell transplant clinical pharmacists to improve patient outcomes. So just an overview of hematopoietic stem cell transplantation. So our bone marrow is the site of origin and proliferation of various blood cells, including our red blood cells, white blood cells, and platelets. And given that the site is a site of cellular proliferation, it also has a high risk factor for mutation. So these patients can be affected by various malignancies. This includes like red blood cell malignancies, mainly aplastic anemia, as well as white blood cell malignancies, including acute lymphoblastic leukemia, acute myeloid leukemia, as various different lymphomas and myelomas. And when it affects platelets, it could also present as idiopathic thrombocytic purpura. So the purpose of transplantation can either be cure or stabilization. So when it's a disease such as like acute myeloid leukemia or acute lymphoblastic leukemia, we can use transplantation to try to overcome the bone marrow of the recipient and reset it, and essentially have the new immune system active to act as a cure for the malignancy. Whereas in like a condition where it's not curable, such as multiple myeloma, we use it to stabilize the patient, so we stop progression of the disease. And this is also present in amyloidosis as well. So I mentioned a few things in the past slide, including myeloid cells as well as lymphoid cells that primarily affect the AML and ALL patients. But in terms of hematopoiesis, we're actually concerned with the progenitor cell, so the multipotential hematopoietic stem cell, or hemocytoblast. These cells are not specialized, but they're capable of proliferation and differentiation. And these are the cells that give rise to red blood cells, granulocytes, monocytes, and platelets. Whereas like the lymphoid cells give rise to like the lymphocytes, and your myeloid cells give rise to your blood cells and granulocytes. So there's different types of transplantation. You have autologous transplantation, which is from the patient, where there's no evidence of the disease. And these patients don't typically suffer from any like graft versus host disease effect. There's lower rates of complication and mortality and higher rates of relapse. And then there's allogeneic stem cell transplantations, which is primarily what we'll be talking about today. It's from one patient to another patient, or one person to another person, whether they're related or not. And in this instance, the disease can be present, and this transplantation is associated with graft versus host disease or graft versus leukemia effect, and also high rate of complications and mortality and lower rates of relapse. Another subset of transplantation is syngeneic transplantation, which is from an identical twin. So although this is from another individual, since their genetic makeup is the same, it kind of works similarly to the autologous transplantation. So we have these different types of donors. How do we ensure that we're obtaining the multipotent stem cell that we're looking for? So we look for the CD34 cell. It's a surface antigen that's present on immature hematopoietic cells and a cell marker to identify early progenitors. It's easily measured in the blood, and the peripheral blood stem cell collections allow us to kind of subjectively calculate the number of which correlates to the units of granulocytes or macrophages that are found in the blood. In a bone marrow biopsy, in order to get an accurate assessment, they typically remove a volume of 10 to 20 milliliters per kilogram to a CD34 count of 1 to 4 times 10 to the 8th per kilogram with a max volume of 1,500 mLs. So the rationale for hematopoietic stem cell transplant, in the case of autologous transplant, it's typically used when patients are given high dose chemotherapy and their bone marrows are completely depleted. And we give their own cells back to them to essentially give them like a jump start in terms of their immune system. In allogeneic transplantation, it's more of like a rescue. So we completely deplete the bone marrow that's present and we kind of reset it with another individual's bone marrow. And then there's also this effect called graft versus leukemia effect, which is essentially if there's any residual cancer or malignancy left in the patient, this transplantation can actually eradicate that residual disease. And the transplant activity in the United States has steadily been increasing, both in terms of allogeneic hematopoietic stem cell transplantation, as well as autologous hematopoietic stem cell transplantation. So there's different types of graft sources, and it's relevant given the patients that are receiving them. So in terms of the bone marrow, this is bone marrow collected from the iliac crest via repeated aspirations. And there's more commonly used now is peripheral blood stem cell transplantation, where stem cells are mobilized from the marrow to enter peripheral circulation, which are then collected by leukapheresis. They mobilize them from the stem cell by giving patients colony growth stimulating factors such as filgrastim. And this type of stem cell transplantation has a faster engraftment height, but is also associated with higher risk of chronic graft-versus-host-disease, but there's no difference in survival of patients. And then there's a last type, it's umbilical cord blood transplantation, and which is typically used for patients without suitable HLA matched donors. And these donor cells are immature, which allow for a greater mismatch. And there's a longer time to engraftment and a higher risk of infection, but a lower risk of graft-versus-host-disease. So in terms of timing of transplantation, when it comes to malignancies, it really depends on the course of your disease. Essentially, patients will require multiple cycles of chemotherapy before they receive hematopoietic stem cell transplantation. And the timing that you give it depends on how high risk the disease is. So in terms of like high risk AML, after a patient receives a complete remission, number one, you typically give them hematopoietic stem cell transplantation. But let's say a patient is presenting with an incurable disease, such as multiple myeloma, then you would give the hematopoietic stem cell transplantation at first progression. So in terms of patient evaluation, it's important that we look at the complete history and physical exam of the patient, including their CBC with differential and a chem panel, as well as a viral panel, blood typing, an echo for ejection fraction, and pulmonary function tests. The blood type doesn't have to be matched up in bone marrow transplant, but it's definitely taken into consideration for any issues that may arise. So let's say a patient has a major ABO mismatch, then we know that we're concerned for any hemolysis that might occur. But typically these days in major ABO mismatch hematopoietic stem cell transplant, this hemolysis can be prevented by removing the erythrocytes from the graft. And then the reasoning behind getting an echocardiogram as well as pulmonary function tests is because these patients, when they present for transplantation, we give them conditioning regimens that include various chemotherapies that can alter their baseline function. So it's good to get that echo and pulmonary function test to see if a patient's baseline status has changed. So now moving into HLA antigen matching. So how do we know that a patient is matched, a donor and a recipient are matched? So we use this HLA antigen system. It's a major histocompatibility complex located on the short arm of chromosome 6. And class 1 antigens include HLA-A, HLA-B, and HLA-C. And our class 2 antigens are HLA-DR, HLA-DP, and HLA-DQ. And HLA matching is important when looking at the genetics of patients because it improves transplant survival. It reduces any post-transplant disorders, including acute graft-versus-host disease, and improves engraftment. which is essentially the donor bone marrow taking over and initiating an immune response in the recipient. So this is just a visual to give patients a visual of HLA matching. So we have this patient here. We have his genetics from his parents as well as his siblings and children. Does this patient have a direct HLA match based on the imaging? Yep, so the answer is no here. This patient doesn't have a full HLA match. Their genetics from their mother and father, as well as their siblings and children, don't match the HLA subtypes that the patient is presenting with. Just an overview of the types of allogeneic transplants. So you'll typically see this nomenclature in charts. There's different types. So there could be a related match donor with a 10 out of 10 antigen matching. There could be a mismatch where a patient presents with 9 out of 10 antigens, or haploidentical, which is 3 out of 6. And the patient donor could also be unrelated. So it could have a match unrelated donor where all the antigens match, or a mismatched donor where only 9 out of 10 or 8 out of 10 antigens are matching. So this is our first clinical vignette. PK is a 65-year-old female with AML and complete remission number 1, undergoing her transplant assessment for donor status. The HLA report comes back with the following potential donors. Based on the above HLA report, which is the best donor for your patient and why? Yep, exactly. So donor number 1 is an exact match. So that would be the ideal donor for your patient. Now, this just gives us an overview of the transplantation schedule. So things that I wanted to highlight here are, in regards to timing in the chart, you'll see that day 0 is the day of transplant. Day -8 or further is prior to transplant, and it typically in the chart it will refer to like any conditioning regimen the patient received, and anything above day 0 is the future. And another thing I wanted to highlight here is that once the hematopoietic stem cell transplantation occurs, the time for engraftment is later on. So engraftment is when the donor immune system kind of takes over the recipient's immune system. And in the interim time of when your immune system is getting in order, the patient can suffer from various different types of diseases, including bacterial infections, immunosuppressant related comorbidities, as well as viral infections. So it's definitely something that we have to look out for. So I've talked about engraftment a few times now. So what is the exact definition of engraftment? So it's a sustained absolute neutrophil count of greater than 0.5 times 10 to the 9th per liter, and a platelet count of greater than 20 times 10 to the 9th per liter for 2 consecutive days. And what's important to note here is that patients that receive peripheral blood transplants tend to have a faster median day to the goal, as well as the median day to 50 platelets, as opposed to bone marrow and cord blood transplants. And then typically the patients that receive these hematopoietic stem cell transplants will be given various prophylactic regimens. This includes bacterial prophylaxis. So in early states of disease, days 0 to 100 after hematopoietic stem cell transplant, patients are likely to suffer from a gram-negative bacteria. So they'll be on prophylactic regimens of fluoroquinolones, namely levaquin, 750 milligram once daily. In late disease of greater than 100 days after hematopoietic stem cell transplant, they could be suffered from a bacterial infection with an encapsulated organism, namely strep pneumo or H flu. So prophylactically, they'll put patients on penicillin 500 milligrams twice a day. And then there's viral prophylaxis, typically with acyclovir 400 milligram BID to TID, as well as the valcyclovir 500 milligram twice daily. And then if your patient, if the recipient is cytomegalovirus IgG positive, then you'll give them this drug called letermovir. It's dosed at 480 milligrams daily with acyclovir. So the reasoning behind this is letermovir only covers a patient for treatment of cytomegalovirus. It doesn't cover HSV or VZV. And this CMV, it relies on the DNA terminase complex for processing of viral DNA. And the viral DNA is produced in a single repeating strand and then cut by a DNA terminase. So the letermovir kind of prevents the capsid formation, and it's used to treat cytomegalovirus, but you give it in conjunction with acyclovir, given that it doesn't cover the other viral disease that you have to cover for. And then patients will be on fungal prophylaxis. So allogeneic hematopoietic stem cell transplant patients will be on voriconazole, typically, or posaconazole. And you have to look out for CYP3A4 interactions with those drugs. And then just PJP prophylaxis. So patient will typically be on Bactrim, or if Bactrim's contraindicated, most of the time they're on a pentamidine infusion, dosed at 4 milligrams per kilogram every 28 days. So getting into acute graft-versus-host disease itself. So just an overview here on the top left, we kind of have what we talked about prior. So a patient, donor is stem cells collected, processed and cryopreserved, probably with DMSO, and the recipient receives the drug after being conditioned with total body irradiation or chemotherapy. And what happens is the acute graft-versus-host disease picture kind of occurs within 0 to 100 days post-transplantation. So what exactly happens in acute graft-versus-host disease? So basically, these patients, they receive a conditioning regimen chemotherapy, and the pathology is that in phase 1, after receiving this transplant and the chemotherapy, the damage to the host tissue from preparative chemotherapy causes inflammatory cytokines being released. And antigen presenting cells and these inflammatory cytokines trigger donor T cells from the transplant to be activated. And once these activated T cells are kind of proliferating throughout the body, they target the host cells and cause direct damage to our skin, GI tract, and liver. So what is a typical presentation of a patient with acute graft-versus-host disease? So you'll notice on their skin that they have this maculopapular rash and pruritus. In the GI tract, they have secretory diarrhea, abdominal cramping, vomiting, nausea, anorexia, dyspepsia, as well as a severe abdominal pain with or without ileus. And it affects their liver as well. So the patient will typically present with hyperbilirubinemia of greater than 2. And the reasoning behind the pathology is that when we're kind of looking at patients in terms of hosts and donors, we look at the HLA antigens. So the class 1 antigens, the A, B, and C, are primarily found on every nucleated cell, but the class 2 antigens are primarily found on epithelial cells, so your DR and your DQ. And we kind of reason to think that this is why these are the targets of acute graft-versus-host disease. So what are the risk factors for acute graft-versus-host disease? The major risk factor that we're looking at is any degree of HLA mismatch. But other risk factors include an older age recipient, a multiparous female donor to male recipient. So multiparous meaning that a female that has given birth. And the reasoning behind this is because extra exposure to antigens during pregnancy can cause a higher degree of HLA mismatch when patients donating their stem cells. Patients that typically receive stem cells from peripheral blood rather than the bone marrow or umbilical cord blood. Ineffective graft-versus-host disease prophylaxis, increased conditioning regimen intensity, as well as cytomegalovirus serostatus are all risk factors for acute graft-versus-host disease. So in terms of staging, we have this MAGIC criteria. It's the Mount Sinai Acute Graft-Versus-Host Disease International Consortium criteria. And this allows us to objectively look at patients to see how their disease is progressing. So each organ system involved is individually staged from 1 to 4 based on the degree and severity of involvement. And then based on the staging, these patients are graded. So this gives us an overall acute graft-versus-host disease grade from 1 being mild all the way to 4 being life-threatening. And we have this Minnesota risk score for acute graft-versus-host disease. And this gives us an idea to see if patient presenting with graft-versus-host disease, is it really important for us to know what the outcome will be to standard treatment? And basically what they did is they looked at patients with standard risk, where their stage was kind of low, 1 to 3 in skin, 1 to 2 in GI, or a high risk patient with multiple organ involvement at a higher acuity. And what they found was that the patients in the high risk acute graft-versus-host disease criteria were less likely to respond to systemic steroids compared with the standard acute graft-versus-host disease patients. And they also had a higher incidence of transplant-related mortality. So this leads us to our second clinical vignette. So SW is a 25-year-old man presenting to the BMT clinic follow-up after receiving a matched unrelated donor with pentostatin and TBI for high-risk AML. He's currently plus 30. His current medications are as follows. And after speaking with the patient, you find out that that he's experiencing significant diarrhea at home, 4 bowel movements a day with approximately 900 mLs of stool output in the last 24 hours. What grade is SW experiencing? Exactly. So yep, this patient is experiencing grade 2. So how do we find that out? So this patient is having 900 mLs of stool output. So that's puts him at stage 1 of the staging criteria for acute graft-versus-host disease. And then based off his stage 1, he would be grade 2 because he has stage 1 lower GI involvement. So how do we prevent acute graft-versus-host disease? So the most important thing is HLA matching. But also recently there's been a movement where we're able to remove T cells from the stem cells, as well as T cell depletion by antibodies, and also using immunosuppression in patients that are receiving hematopoietic stem cell transplantations. So this includes typically cyclosporin, tacrolimus, methotrexate, or mycophenolate. And just an overview of the timeline. So in 1956, there was a wasting syndrome noted in rodents. In 1957, we performed the first hematopoietic stem cell transplantation in humans. And these patients had a universal mortality of, including infection, graft-versus-host disease, as well as relapse. In the 1970s, there was the first reported case of using methotrexate prophylaxis, as well as cyclosporin treatment. In the 1980s, the hallmark of cyclosporin and methotrexate, or tacrolimus and methotrexate, became present. And in the 2000s, they started using the post-transplant cyclophosphamide, tacrolimus, as well as mycophenolate. This is typically used in patients with haploidentical transplants, as well as Clinimax, which is like a procedure used for T cell depletion. And this reduces or prevents both acute and chronic graft-versus-host disease in HLA-matched and haplotype disparate hosts without post-transplant prophylaxis with immunosuppressive drugs. And this is just a visual. So allogeneic hematopoietic stem cell transplantation by donor type, given that there have been newfound ways to combat graft-versus-host disease and transplantation-related comorbidities, there's been a growth of transplantation overall. But if you look at this chart as well, the light green with the circle, the haploidentical individuals with greater than or equal to 2 HLA antigen mismatch has been steadily increasing. And this is probably because of our both our immunosuppressive therapies that have been effective in preventing any complications, as well as the biomechanical ways of removing T cells from stem cell transplantation. So in terms of prophylaxis in preventing graft-versus-host disease, there's currently no FDA-approved preventative measures for acute graft-versus-host disease. The bone marrow transplant guidelines recommend using immunosuppressants. So typically a calcineurin inhibitor and an anti-metabolite. So a calcineurin inhibitor would either be your tacrolimus or your cyclosporin, and your anti-metabolite typically in these regimens is your methotrexate. So those are the hallmarks of prevention. And how do calcineurin inhibitors work? So calcineurin is a calcium-dependent phosphatase that dephosphorylates and further activates this molecule called NFAT, which in turn provokes IL-2 production. IL-2 is an inflammatory cytokine, and calcineurin is activated by liberated calcium from the endoplasmic reticulum in T cells. So these calcineurin inhibitors kind of prevent the release of this calmodulin and downstream prevent the release of IL-2. So what typical immunosuppressants do we use? How do we kind of monitor them, and what are their common adverse effects? So we have our calcineurin inhibitors, cyclosporin and tacrolimus. These are both given IV initially in hematopoietic stem cell transplant patients. So you have cyclosporin at a range of 250 to 450, starting dose of 2.5 milligrams per kilogram, IV Q12. You typically start this regimen at day -3, or you have your tacrolimus with a monitoring range of 5 to 15 nanograms per milliliter. And this is a continuous infusion that's also started on day -3. Typically, it's 0.02 to 0.03 milligrams per kilogram IV. And the common adverse effects that I like to highlight are your electrolyte abnormalities. So you have hypomagnesemia, hypokalemia, as well as hyperglycemia are the hallmarks of giving these calcineurin inhibitors. Also present on the slide are your sirolimus and mycophenolate, which aren't used as commonly. Moving on, we have cyclophosphamide, as well as antithymocyte globulin and methotrexate. What I'd like to highlight here is the dosing for the methotrexate. So standard dosing is 15 milligrams per meter square on day 1, and then 10 milligrams per meter square on day 3 and day 6 and day 11. If your patient is elderly or they're frail, typically the physicians will try to use this mini methotrexate, which is a dose-reduced methotrexate of 5 milligrams per meter square on day 1, day 3, day 6, and day 11. And with methotrexate, you have to monitor the patient for any mucositis, any renal dysfunction, and any hyperbilirubinemia. And the monitoring parameters kind of vary from institution to institution. So just giving us a little bit more in-depth analysis on our calcineurin inhibitors. So cyclosporin, brand name Sandimmune, like we mentioned, inhibits IL-2 production. You start at day -3. And common drug interactions you have to look out for are your CYP3A4 inhibitors, including your azole drugs, voriconazole, posaconazole in particular. And the trough level that you're looking at is 150 to 400 nanograms per liter. So we have a chart here on our intranet that helps manage the dose of the IV that you're giving. And if it gets off range, then we can decrease the dose or increase the dose respectively. From converting an IV to PO dose, you take the 24-hour IV cyclosporin dose, you multiply it by a conversion factor of 2, and then you divide it by 2 doses per day to give the dose to be given every 12 hours. Tacrolimus' brand name is Prograf. Also started at day -3. Also, you target a trough of 5 to 15, and there's a chart in the intranet to help dose it based off that trough level. The drug interactions that you look for are the same. It's just that when converting from IV to oral tacro, the dose conversion is typically 1 to 3 or 1 to 4. And the formula given is a 24-hour continual IV dose. You multiply that number by 2, and that gives you the dose to be given every 12 hours. And then we have also an extended release tacrolimus. So converting from intermittent release tacro to extended release tacro, you multiply the total daily dose by 0.8. So they did some studies on these preventative regimens that patients receive in the improved outcomes after GVHD in the modern era. It was a retrospective analysis from 1999 to 2012 with patients with grade 2 to 4 acute graft-versus-host disease. And the results were overall survival and total transplant-related mortality in patients that received tacrolimus-based graft-versus-host disease prophylaxis led to better outcomes for patients. There was no significant difference over time with patients that received cyclosporin. And this is why tacrolimus and methotrexate is kind of the hallmark of preventative measures in hematopoietic stem cell transplantation patients. Another important study that I'd like to highlight is the impact of blood concentrations of calcineurin inhibitors on graft-versus-host disease. So this is a single center retrospective analysis of 1,181 patients post-allogeneic hematopoietic stem cell transplantation from either a match-related donor or a match-unrelated donor. And after non-myeloablative allogeneic hematopoietic stem cell transplantation, the higher week 2 median tacro and cyclosporin levels resulted in a decreased incidence of grade 3 to grade 4 acute graft-versus-host disease. So as pharmacists, this is kind of an area that we can be involved in to ensuring that post-transplant, these patients have on the higher end of the trough levels to ensure prevention of acute graft-versus-host disease in these patients. So our patient, let's say a patient comes in and they actually have the disease, even though they receive preventative measures. How do we go about treating it? So acute graft-versus-host disease occurs in 20 to 80% of post-allogeneic stem cell transplantations, regardless of preventative measures that we take. And the main first-line therapy that we use is systemic corticosteroids. Typically, if it's a grade 1 picture for acute graft-versus-host disease, and you can consider skin-directed topical treatment with steroids. But if it's a grade 2 to 4, then methylprednisolone of 0.5 to 2 milligrams per kilogram per day is preferred. Steroid doses are greater than 2 milligrams per kilogram have not shown to improve efficacy at all, so they're not recommended. And then in terms of tapering, the American Society of Transplant recommends tapering by 0.2 milligrams per kilogram per day every 3 to 5 days once these graft-versus-host disease symptoms are under good control. This leads us into our next clinical vignette. So this is the same patient that having this 900 mLs of stool output in the last 24 hours. What therapy should you initiate to help treat his symptoms? Exactly, yep. So methylprednisolone at a dose of 0.5 to 2 milligrams per kilogram per day. And how do we know that the steroids are being effective or not? And what is like the timeline that we look at? So progression of acute graft-versus-host disease within 3 to 5 days of therapy onset with greater than or equal to 2 milligrams per kilogram per day of prednisone, or failure to improve within 5 to 7 days of treatment initiation is considered steroid refractory or resistant acute graft-versus-host disease. There's also a phenomenon known as steroid dependence, which is the inability to taper the prednisone, as well as steroid intolerance, which is like an emergency of unacceptable toxicity due to the use of steroids. It's very important to realize when your patient becomes steroid refractory, the 6-month overall survival of patients that have acute graft-versus-host disease with the steroid refractory picture is 50%. So how do we treat these steroid refractory patients? So the treatment options for steroid refractory acute graft-versus-host disease include the FDA-approved ruxolitinib, as well as various other off-label use medications, including your alpha-1 antitrypsins, as well as tocilizumab, which you guys may be familiar with in terms of COVID-19. So what is ruxolitinib? So it works on your brand name Jakafi, works on your JAK-STAT pathway. So what is JAK-STAT? It's a signaling pathway for pro-inflammatory cytokines through the JAK1, JAK2 to activate antigen-presenting cells. It causes proliferation and activation of T cells and suppression of regulatory T cells, and it activates an immune cell migration and tissue damage. So ruxolitinib selectively inhibits both JAK1 and JAK2. And typically you would start a patient at 5 milligrams twice a day, and you increase the dose to 10 milligrams twice daily after greater than or equal to 3 days of treatment, if their absolute neutrophil count and platelet counts are not decreased by 50% or more. What's important to note with this medication is that no dose adjustment is necessary for CYP3A4 inhibitors when treating acute steroid refractory acute graft-versus-host disease, except for ketoconazole. And the dose reduction you would do in light of ketoconazole would be 5 milligrams daily instead of the twice a day. So ruxolitinib was studied in the REACH1 trial, which is a phase 2 trial, where they evaluated the efficacy and safety of ruxolitinib for the treatment of steroid refractory acute graft-versus-host disease. And the primary endpoint that they looked at was overall response rate at day 28, as well as secondary response rate of duration of response, and time from first response to graft-versus-host disease progression or death. And what they found was that the overall survival in terms of 6 months was 51% in the ruxolitinib group, as well as a 12-month overall survival of 42.6%. And the 6-month non-relapse mortality was 44.4%. And the main hematologic adverse event was anemia and thrombocytopenia in patients that received the ruxolitinib. Ruxolitinib received this FDA approval in December of 2019 based on that phase 2 trial. But we're, as clinical pharmacists, we have to see whether or not the newly implemented therapy is just as effective as the therapy that has been given in the past. So we did a phase 3 study where they compared efficacy and safety of ruxolitinib with investigator choice of therapy in patients with steroid refractory acute graft-versus-host disease. This is a phase 3 trial where they compared ruxolitinib 10 milligrams twice a day versus the best available therapy, which they defined as the scientist's choice of antithymocyte globulin, extracorporeal photopheresis, as well as low-dose methotrexate and mycophenolate. And the endpoint was primary overall response at day 28. And what they found is that the overall response at day 28 was statistically significant and higher in the ruxolitinib group as opposed to the control groups. And the durable response was also higher in the ruxolitinib group. The median failure-free survival was longer in the ruxolitinib group, which was 5 months as opposed to 1 month. And the median overall survival was 11.1 months in the ruxolitinib group. Also, what's been studied is tocilizumab. So tocilizumab is an anti-interleukin-6 antibody, and it's a cytokine that appears to be especially important in causing this cytokine release syndrome associated with acute graft-versus-host disease. The patients that present with acute graft-versus-host disease tend to have a higher IL-6 value, both prior and post hematopoietic stem cell transplant. So they studied Actemra, which is the brand name of tocilizumab, in this setting. Patients received 8 milligrams per kilogram IV every 2 to 4 weeks, and the overall response rate was 44% to 67%. And the median overall survival was longer in the responders versus the non-responders. And the typical adverse effects were elevated transaminases as well as bacterial infection. Another group of medications that's recently studied in acute graft-versus-host disease has been your alpha-1 antitrypsin. These are naturally occurring serine protease inhibitors containing anti-inflammatory, anti-apoptotic, and immunomodulating properties. And these patients, they received AAT at 60 milligrams per kilogram IV twice weekly for 4 weeks, 8 doses in 40 patients. And the overall response rate by day 28 was 65%, with responses sustained at day 60 in 73% of patients. And the complete response rate by day 28 was 35% in the patients that received alpha-1 antitrypsin. This leads us to our next clinical vignette. So our same patient comes back into the clinic, and we notice that his graft-versus-host disease has been progressing. His bowel movements, even with the methylprednisolone that we prescribed him, has led to bowel movements of 2,000 mLs of stool output per day. And the BMT physician decides to admit the patient. Given that the patient is refractory to the methylprednisolone, what option does he have that's FDA approved to treat his GVHD? Perfect. Yep. So ruxolitinib is the answer, and that's what we would use. We would start the dose at 5 milligrams twice daily. And now just going over the role of the hematopoietic stem cell transplant pharmacist. So the hematopoietic stem cell transplant pharmacists can help with medication management. This includes medication review, management of chemotherapy processes, pharmacokinetic dose adjustments, as well as renal and hepatic dosing. And what's really essential is therapeutic drug monitoring. So immunosuppression monitoring, so your TACRO levels, as well as your cyclosporin levels, ensuring that patients are on appropriate anti-infectives, and making sure that there's no drug interactions that exist on those therapies, as well as like chemotherapy related side effects, ensuring patients are on proper therapy. And while attending interdisciplinary rounds, providing supportive care to patients, dealing with adverse drug events, helping the patient transition, when they're admitted, providing a medication reconciliation, as well as like long-term follow-up as well. And another thing I want to highlight is that I think that's overlooked quite often is post-transplant vaccine administration. So like we mentioned earlier, these patients don't present with their original vaccination schedules. These patients are kind of, their immune systems are eradicated, and you're implementing a new immune system essentially by having that stem cell transplanted. So the IDSA actually recommends, has like guidelines for recommendations of vaccination schedules for patients that receive these transplants. And typically, you have to ensure that the patient receives the appropriate vaccinations. This includes like your H flu vaccination, the hepatitis vaccination, PPSV 23, as well as like childhood vaccinations that you typically don't see in adults, such as like MMR. So just our key points. In match-related and unrelated hematopoietic stem cell transplants, tacrolimus and methotrexate remains the current standard of care for acute graft-versus-host disease prevention, but ongoing studies may change this paradigm. Corticosteroids are the standard of care for initial treatment of acute graft-versus-host disease, with newer therapies impacting the treatment landscape. Ruxolitinib is currently the only FDA-approved drug for steroid refractory acute graft-versus-host disease, and pharmacists play a key role in caring for patients pre and post hematopoietic stem cell transplant. And I'd just like to acknowledge Tyler Hertz, as well as Amanda Waldeck, for their help with this presentation. And that's the conclusion. Thank you so much for attending. If you have any questions at all, kindly, you can ask both verbally or type in the chat. All right, so there's no questions. Thank you again all for attending. I hope it was an educational experience. Thank you.